Hello everyone. Heather Hames speaking to you from the Division of Emergency Medicine Point of Care Ultrasound program at Western University. Welcome to this installment of our Practical Point of Care Ultrasound series. This screencast will focus on the use of point of care ultrasound in the diagnosis of small bowel obstruction. We will cover image generation and interpretation, as well as some evidence behind using your bedside ultrasound machine in the diagnosis of this common ED presentation. Is there a new reason to pick up the probe? And is it time to say goodbye to x-rays? Let's start with a case. An 83-year-old woman presents with abdominal pain after a day of feeling unwell. She has vomited a couple of times. She is tachycardic and hypotensive, especially given her past medical history of hypertension, and she is on quite a few medications. Your differential diagnosis at this point should be quite broad, and there are lots of reasons to pick up the probe in an effort to eliminate some of the most dangerous on your list. You certainly would like to rule out a AAA, and you may want to rule out free fluid as well. But let's say while you're doing that, you stumble across an image that looks like this. Could this be helpful? Have you come across the diagnosis? So that brings us to the purpose of this screencast, which is POCUS for small bowel obstruction. And is this actually a thing? So on that note, let's have a look at this patient's x-rays. Perhaps what should not be a thing is x-rays. We all do them, but how often do we see an image that looks like this? Do these x-rays show a small bowel obstruction? Did they rule it out? Or did we just send someone out of the emergency department for a test that often comes back as inconclusive, and we are no further ahead? In fact, this is the radiology interpretation of these films. A nonspecific gas pattern, a common scenario. These numbers come from a study published in the American Journal of Gastroenterology in 1991, so an older study for sure. They used enteroclysis, which is a technique of watching contrast travel through the bowel, and operative findings as the gold standard. Here, the sensitivity of x-rays in the diagnosis of small bowel obstruction was 66 to 77%, and the specificity was 50 to 57%, or effectively a coin flip. Rosen's textbook of emergency medicine has this to say about x-rays. Plain radiographic findings are estimated to be diagnostic in approximately 50 to 60% of cases, equivocal in 20 to 30%, and normal, nonspecific, or misleading in 10 to 20%. Today, the non-invasive or non-operative gold standard in diagnosis remains CT scanning. In a systematic review of 743 patients published in 2005, the sensitivity for CT scanning was 92% and the specificity was 93%, compared to operative findings or enteroclysis. In fact, this is the CT report of a patient who presented with the equivocal x-rays. The findings were in keeping with a high-grade small bowel obstruction. But of course, there are some downsides to CT imaging, including radiation exposure, IV contrast exposure, and time to completion, especially when oral contrast is used, which is the case when the indication is to rule out a small bowel obstruction. And the patient often needs to leave the emergency department for the imaging. So how does point of care ultrasound stack up? Well, in this study, published in 1996, it turns out it stacked up pretty well compared to the numbers published in the previous studies. Ultrasound had an 88% sensitivity and a 96% specificity in the diagnosis of small bowel obstruction. Compared to X-ray, something most of us order without hesitation, ultrasound compares quite favorably. So when it comes to POCUS for small bowel obstruction, what is it we're looking for? It was first described in 1979. As you know, ultrasound is not like air. One of the reasons a AAA scan can be rendered inconclusive is of course that pesky bowel gas. So ultrasound is best for small bowel obstruction in the setting of fluid-filled bowel. We are looking for several characteristic features. Dilated bowel, back and forth or to and fro peristalsis, the Tanga sign, which we will discuss in more detail shortly, and bowel wall thickening, generally considered to be greater than 3 millimeters. Normally, you won't see the bowel well because you'll just see air, but here we clearly see bowel which is fluid-filled, and the diameter measured with calipers is 3 centimeters. If you see multiple dilated loops, this is even more suggestive of a small bowel obstruction. This clip shows an example of to and fro peristalsis. This finding makes sense. Because there is a distal obstruction, the fluid and bowel contents do not just move forward with peristalsis, but instead move back and forth. This is an example of what is called the tanga sign. This clip shows free fluid between the bowel loops. Let's talk briefly about the relevance of viewing small amounts of free fluid in between bowel loops. This study was published in a radiology journal in 2004. 750 people were included and had an X-ray and ultrasound done prior to any intervention. This study looked at 150 of them who had a small bowel obstruction confirmed at surgery. 105 of these had extraluminal fluid. They found that this presence suggested a higher grade of small bowel obstruction. In 70 of them, the fluid was serous and turbid, and the loops near the obstruction were dilated but still thin. In 34 of these, they found the fluid was serous and bloody, with thickened bowel walls and evidence of necrosis. And in those without extraluminal fluid, they found thin-walled bowel. So the conclusion was that the presence of extraluminal fluid signified a worsening or higher grade obstruction. The pathophysiology goes like this. Intraluminal pressure exceeds capillary pressure, and this results in a change in permeability, and therefore extraluminal fluid. Edema and bowel wall thickening follow, and this thickened bowel wall may be followed by thrombosis and intestinal ischemia. Now this is an example of what thickened bowel may look like on ultrasound. Although this is an example of large bowel, thick and small bowel would look similar. In terms of defining how thick is thick, the numbers vary slightly depending on your source, but approximately 3 millimeters or greater would be considered thicker for small bowel. So we may now believe that POCUS for small bowel obstruction can be a thing, and we know what to look for, so how do we do this? Let's start with probe selection. The curvilinear probe seen here on the left is likely the best for resolution and penetration, and also for having a larger footprint, enabling you to cover more ground, so to speak, and scan more area at once. The phased array probe seen on the right is also an acceptable option. In fact, in the very thin patient, you could even use the linear high frequency or vascular probe. So how do you do this? Well, given the small bowel has the ability to be essentially anywhere in the abdomen, the goal is to systematically scan the abdomen looking for abnormal bowel, or essentially mowing the lawn. The probe movements shown here illustrate this technique. Start in the right lower quadrant, move up to the right upper quadrant, and then back down and back and forth until the entire abdomen is scanned. So now we know how to do this, and we know what to look for. The next question is, should we as emergency physicians be doing this? This study was published in 2011 in the Journal of Emergency Medicine. They looked at a prospective convenient sample of 76 patients suspected of having a small bowel obstruction and used CT as their gold standard. The ultrasound criteria they looked for was dilated bowel and decreased bowel peristalsis. They did not look for the tanga sign or back and forth peristalsis. In this study, the sensitivity and specificity of X-ray was 46 and 67% respectively. In terms of point-of-care ultrasound, they found that the presence of dilated bowel had a sensitivity of 91% and a specificity of 84%, and the presence of decreased bowel peristalsis, while not very sensitive, was 98% specific in the diagnosis of small bowel obstruction. But most interestingly, the point-of-care ultrasound in the study was performed by emergency physicians who had only participated in a 10-minute training module and had only had 5 prior exams. This is another study published in 2010. They had 174 patients suspected of having a small bowel obstruction. They compared point-of-care ultrasound performed by emergency residents with 6 hours of training to formal ultrasound performed by radiology residents. Their gold standard was surgical findings, or in the case of someone who did not receive an operation, investigator follow-up. This study showed the sensitivity and specificity of POCUS to be nearly 98 and 93% respectively, and of all the ultrasound findings, dilated bowel was the most sensitive. They also noted that there was no statistically significant difference in diagnosing small bowel obstruction between emergency medicine and radiology residents. As with everything, there are of course limitations to using bedside ultrasound. Using the mow the lawn approach, you attempt to cover the entire abdomen, but it is still possible to miss or not see some dilated loops of small bowel depending on their position. Secondly, it is often very difficult to find a transition point, and as such, differentiating from ileus can be challenging, and clinical judgment must also always be applied. Also, it is rare to be able to determine a cause of obstruction with POCUS. While an intraluminal mass or a thickened loop of bowel may suggest a cause, adhesions, one of the most common causes of small bowel obstruction, likely can't be seen. Okay, so at least locally, our surgeons like to CT all potential small bowel obstructions. Perhaps practically the next steps are with radiology, decreasing the number of x-rays ordered when the ultrasound is suggestive of a small bowel obstruction. So in summary, is POCUS for small bowel obstruction a thing? Yes, definitely helpful, especially with fluid-filled bowel. What are we looking for? Dilated loops, to and fro peristalsis, the Tanga sign, and thickened bowel. How do we do this? Mow the lawn. And should we do this? Yes. So hopefully you go out there and try this out. It may help you and your patients. Thanks for listening. Please be sure to check out our other POCUS screencasts and videos on westernsono.ca.